Good morning. Today we will talk about two infections in pregnancy, viral hepatitis and HIV. So starting with viral hepatitis in pregnancy. Viral hepatitis is the commonest cause of jaundice or hepatic dysfunction in pregnancy. Good morning. Today we will talk about two infections in pregnancy, viral hepatitis and HIV. So starting with viral hepatitis in pregnancy. Viral hepatitis is the commonest cause of jaundice or hepatic dysfunction in pregnancy. And it is the common viruses are hepatitis A, B, C, D, and E. Less commonly, cytomegalovirus, Epstein-Barr virus, or herpes simplex virus may also cause viral hepatitis in pregnancy. So overall, considering all the viral infections which cause hepatitis, what is the effect on pregnancy? It may lead to abortions, preterm delivery, maternal mortality may be increased if there is fulminant hepatitis. There may be PPH and coagulation disorders. What is the effect on the fetus? It may affect the growth of the fetus. There may be perinatal mortality, stillbirth, and with some of the viral hepatitis, some of these viruses, there may be vertical transmission. And again, let's see if there is any effect of pregnancy on the severity of the infection. So starting with hepatitis A, it is an RNA virus. Transmission is by fecal-oral route. There is an incubation period of an average 28 days. The diagnosis is by clinical symptoms, which include fatigue, malaise, fever, nausea, anorexia, weight loss, and icterus usually develops 10 days after the infection. And there may be palpable hepatomegaly. Many of the patients may be asymptomatic or anictric. The enzymes may be raised, and the presence of IgM specific to hepatitis A would clinch the diagnosis. This is a self-limiting illness, and there is no chronic carrier state. Hepatitis A is a benign infection mainly. There is no teratogenicity, and there is no increased risk of abortion, stillbirth, or effect on the growth. Although there may be increased risk of preterm labor and premature rupture of membranes, there is no perinatal transmission. The transmission to the fetus is by fecal-oral route at the time of delivery and postpartum, within 2 weeks of maternal infection. That is, if the delivery occurs within 2 weeks of maternal infection. And this infection in the newborn can be sort of prevented by giving immunoglobulin, which is effective, and it is not transmitted in breast milk. Management is usually outpatient with bed rest, diet rich in protein, avoiding hepatotoxic drugs, and monitoring the liver function test and prothrombin time. Hospitalization may be required for patients who are unable to take orally because of nausea or vomiting, if there is severe anemia, diabetes, any other immunocompromised state, if there are abnormalities of the prothrombin time, low serum albumin, the bilirubin is very high, they develop features of fulminant hepatitis, coagulopathy, or encephalopathy. The other virus is hepatitis B infection. So it is also a DNA virus transmitted by contact with body fluids, that is through blood or sexually transmitted. In the developing countries, the most frequent route of transmission is vertical, that is from the mother to the fetus. The incubation period is an average 90 days. Clinical symptoms are like what we discussed with hepatitis A, and also there may be extrahepatic symptoms like arthralgias, rashes, etc. Diagnosis again is by serology. Most of the time it is mild infection, and in a large number it may be asymptomatic. And there is no increase in maternal morbidity or mortality with this infection, nor does pregnancy affect the severity of this infection. Treatment is supportive, same as we discussed for hepatitis A previously. And the effect on pregnancy is increased abortions, preterm delivery, and here in this infection there is a risk of perinatal transmission unlike hepatitis A. So how do we interpret this panel of hepatitis B serology? or the antigen test. If the surface antigen test antibodies to C antigen and S are negative, then the person is susceptible. If the surface antigen is negative and antibodies to C is positive and S is positive, then immunity is due to natural infection. Whereas if antibody to C is negative and only S positive, immunity is due to vaccination. If the hepatitis surface antigen is positive, anti-HC is positive, that is IgM, and surface antigen is negative, then it is acute infection. If the surface antigen is positive, anti-C is positive, but surface antigen is negative, then it is more like a chronic infection. So it is important to understand if the woman is infective, it is acute or chronic infection, because that affects the risk of vertical transmission. So 10 to 20% of women who are seropositive for the surface antigen are going to transmit the virus to the neonate in the absence of immunoprophylaxis. If she is seropositive to both surface antigen and E antigen, the vertical transmission rate is very high, 90%. As also, if the infection occurs in the third trimester, the risk of vertical transmission is 80 to 90%, whereas it is only 10% in first trimester. In India, the prevalence of seropositivity is around 4 to 5% in pregnant women. So we have around 30,000 babies born per year who are carrier. And in Asia, 30 to 40% carriers transmit the virus to infants. What is important to know is that in adults, 10 to 15% will become chronic carriers once they acquire the infection. But if there is a vertical transmission or infection at birth, then 90% become chronic carrier, and there is risk of death from cirrhosis and hepatocellular carcinoma. But this virus is also not teratogenic, that it does not cause structural abnormalities in the fetus. So the most important time of transmission is intrapartum, that is during labor. Also, transplacental passage during pregnancy, postpartum and breastfeeding may also occur. More important is the transmission is more likely to be more if the infection is in the third trimester. If the woman is E antigen positive, there is high viral load. How can we prevent this perinatal transmission? So it is important to test all pregnant women at the first antenatal visit, so that acute immunoprophylaxis can be given to the baby at birth. The women who are at high risk, that is who have history of acute hepatitis exposure or who are drug abusers and all, we also test in the third trimester. Again, for prevention of perinatal transmission, antiretroviral like Lamivudine or tenofovir can be given with women who have high viral load from 28 weeks onwards to decrease the risk of transmission to the baby. So infants born to seropositive mothers should receive immunoglobulins within 12 hours of birth and vaccine first dose at birth to prevent the risk of transmission to the baby, and then additional vaccine at 1 to 2 months and 6 months. For seronegative mothers, only hepatitis vaccine is required. Unknown status, and we can give immunoglobulin if we think the risk is high. So mode of delivery, cesarean section is not required to prevent transmission from the mother to the baby, and breastfeeding with appropriate hepatitis B immunoprophylaxis, it can be allowed. So, and the thing is, like with this immunoprophylaxis, with giving the vaccine and the immunoglobulin, the risk of transmission to the baby can be reduced by 90%. So the women who are carriers of hepatitis B surface antigen, who are chronic and have chronic hepatitis, they may have occasional flare during pregnancy. So the liver function tests have to be done every 3 months till 6 months postpartum. Interferon therapy is contraindicated in pregnancy. Women who develop sequelae of chronic infection like cirrhosis usually have infertility, or if they have become pregnant, they have higher risk of intrauterine growth restriction, preterm delivery, intrauterine death, postpartum hemorrhage, etc. And if they have varices, then they can be bleeding from the esophageal varices. So post-exposure prophylaxis may be required to a person who has had contact with hepatitis B. So if there is a sexual contact within 14 days, then you give a course of vaccine as well as immunoglobulin. If there is percutaneous or mucous membrane injury, then you give a second dose of immunoglobulin 1 month later after giving a course of vaccine and immunoglobulin. Hepatitis D is another virus. Perinatal transmission has been demonstrated. But again, perinatal transmission is rare because immunoprophylaxis of neonate against hepatitis B is 100% effective in preventing hepatitis D, which usually coexists with hepatitis B. The third virus is hepatitis C, which is an RNA virus. Here again, the transmission is mainly parenteral, sexual, and vertical, that is from the mother to the fetus. And most of the patients are asymptomatic. Diagnosis of the detection of the anti-HCV antibody or the viral RNA particles. Pregnancy does not affect the course of infection, and most of the individuals become chronically infected. If there is chronic active hepatitis, then preterm delivery, growth restriction, rupture of membranes, cholestatus of pregnancy, etc. occurs, and maternal morbidity may be increased. The prevalence in pregnant women is around 1%, and 60% will have detectable RNA. That is important because mother-to-child transmission is just around 1 to 2% if antibodies are positive. If viral particles are detectable, it increases to around 4 to 5%. If there is co-infection with hepatitis, the risk of vertical transmission for both HIV and hepatitis C increases. Mode of transmission is usually in utero or at the time of delivery. So transmission again increases with the viral load, but it is not affected by the mode of delivery. So vaginal delivery can be allowed, and breastfeeding can also be allowed. So there is no way to prevent the transmission. There is no vaccine available. And in the newborn, the antibodies from the mother may persist for 18 months. So for a diagnosis, serology diagnosis, we have to wait for 18 months, or HCV RNA, if it is demonstrated in the newborn after 3 to 6 months of life, then we say that the baby is infected. Antiretroviral therapy like ribavirin and pegylated interferon is not recommended in pregnancy. Here again, we screen high-risk pregnant women at the time of booking and later in the third trimester of pregnancy. The third virus, hepatitis E, is important because it can occur as in an epidemic form also, and it is also an RNA virus which is enterically transmitted. It may be asymptomatic or symptomatic infection. Chronic state does not exist, but what is important to understand here is unlike A, B, C, it is a more severe form of disease which can occur in pregnancy, especially if it occurs in third trimester. There is a high risk of maternal morbidity and mortality because of acute hepatic failure, encephalopathy, and coagulopathy. So like different study series have shown high maternal mortality. There is risk of postpartum hemorrhage, intrauterine fetal death, antepartum hemorrhage, and premature rupture of membranes. There is perinatal transmission, and which can result in miscarriage, stillbirth, preterm birth, neonatal deaths, and can affect the growth of the baby. So vertical transmission occurs when the infection occurs in the third trimester, and it's mainly intrauterine, and studies have shown that babies have been born which shows signs of infection if the mother had infection in the third trimester. So maternal HCV is a marker for vertical transmission. The cord blood for HCV RNA or can be done because IgG may persist for many months because it is passively transmitted from the mother. So breastfeeding, the risk of transmission is low, although the viral particles can be demonstrated in colostrum, so it should be avoided in acute infection or if there is high viral load. Again, general preventive measures are important to prevent all these viral infections like hygiene, sanitation, vaccination, post-exposure immunoglobulins, screening for hepatitis B and C in pregnancy for all pregnant women, and universal precautions are important. So with that, we conclude the talk on viral hepatitis in pregnancy. So the second part of the talk is on another infection which is important. And why is it important? Because here again there is a risk of transmission to the baby, and we have strategies which can reduce the risk of transmission from the mother to the baby to almost negligible. So we'll talk about these topics will be covered. Starting with HIV virus, it is a RNA virus, and it's a retrovirus, and the primary infection can occur in the cells in the blood or the mucosa. It targets the CD4 cells. Initially, when the infection occurs, the body immune response overtakes an infection, and after a phase of viremia, the virus lies quiescence. But again, reactivation can occur. leading to full-blown disease. So there are 4 stages of the disease. Initial seroconversion illness, when the patient is symptomatic and the antibodies are not detectable, but they are infectious and CD4 count is normal. Then asymptomatic period, when the body controls the infection, there may be detectable antibodies, there may be normal counts, and the woman is asymptomatic. Then there are subtle symptoms and signs of immunodeficiency. Antibodies are detectable, CD4 counts are falling. Then we have full-blown AIDS with signs and symptoms of opportunistic infections and terminal illness and CD4 counts less than 200. So the prevalence of this virus, HIV, is around 0.26% in the Indian population, and in the women it is 0.2%. And women account for almost half of total HIV infections. What is important is that children less than 15 years account for 6.5% of the population, and most of them have acquired infection in utero or at the time of delivery. So around 10,000 infected babies are born every year without any intervention. So parent-to-child transmission accounts for 5% of all individuals living with HIV. Mother-to-child transmission, which is important because the risk in non-breastfeeding women is 15 to 20%, which almost doubles to 25 to 40% in the breastfeeding population. When does the infection occur? It can occur in utero, transplacental, especially if there is placental inflammation or because of maternal fetal transfusion. The most important time is intrapartum, at the time of delivery, because when the baby comes in contact with the virus infected secretions in the vaginital tract, and then postpartum when the mother is breastfeeding through the breast milk. So the factors which affect perinatal transmission are: if the viral load is high, the CD4 counts are low, then the risk of infection is higher in the baby. Other infections, if they coexist, like hepatitis C, cytomegalovirus, genital tract infections also increase the risk of vertical transmission. Maternal injection use and lack of antiretroviral during pregnancy, they all increase the risk of infection from the mother to the fetus or newborn. The obstetrical factors, if the membranes have been ruptured for a long time, if there is evidence of chorioamnionitis, or if there have been invasive procedures like amniocentesis, etc., or if there has been some instrumental delivery and prematurity. These are also the factors which are going to increase the risk of transmission. But as of today, the risk of perinatal transmission can be reduced to less than 1% with effective antiretroviral therapy, cesarean section and formula feeding, and to less than 5% if the woman is in the breastfeeding population. So that is a reduction from almost 25 to 40% to less than 1%. So let's start with preconception care. So if a couple who is serodiscordant or both the partners infected, if they come for counseling, how do we counsel them? If they're discordant, that means one of the partner is infected, how can we, and they want to plan pregnancy, so how can we advise them? Then the HIV infected partner should be on ART and demonstrate suppressed viral load below detection to reduce the risk of transmission to the other partner. And periconceptionally, the uninfected partner can take pre-exposure prophylaxis 1 month before to 1 month after conception is attempted. Other options could be, if the woman is HIV infected, the safest is artificial insemination with the option of self-insemination also. If the male partner is infected, the options are donor semen intrauterine insemination or intrauterine insemination after semen preparation of the infected partner, or IVF, and the risk of transmission is almost negligible. Again, it is important to look at the mother's infection status, her viral load, immune status, to prognosticate about her illness, to see if she needs to be started on ART. Education and counseling about the risk of transmission to the fetus, the strategies to reduce the risk, effect of HIV treatment and pregnancy course and outcomes should be discussed. And if the woman is not planning pregnancy or wants to defer, then contraception. If she is on ART, then she can avoid drugs which have reproductive toxicity, choose safer drugs, and choose drugs which have been shown to reduce perinatal HIV transmission. She should be started on ART to attain stable, maximally suppressed maternal viral load before planning for pregnancy, because that would also reduce the risk of perinatal transmission. And also we have to look at the side effects related to the ART drugs. If they are, then they have to be treated or the drugs changed. We have to evaluate and treat opportunistic infections if present, and she should be vaccinated for influenza, pneumococcal, hepatitis B, A. We should screen for sexually transmitted infections and other infections like hepatitis B, C, which may coexist, and treat. Also assess, as in any other patient, reproductive and familial genetic history, screen for psychological and substance abuse, counsel her regarding safe sexual practices. Maximum viral suppression before conception in both partners is important, and is initiation of folic acid supplementation at least 3 months before she gets pregnant. So once she's pregnant, again antenatal care is important. Ideally, all pregnant women should be offered screening for HIV early in pregnancy with the option of opting out, that is voluntarily, because if she is found to be HIV positive, there are appropriate antenatal interventions which can reduce the mother-to-child transmission of HIV. And women diagnosed to have HIV infection should be managed by a multidisciplinary team of HIV physician, obstetrician, pediatrician, psychiatric team, and support groups. So whom to screen? All pregnant women coming for antenatal care should be screened early in pregnancy. Those at high risk should again be screened in the 3rd trimester. With pre and post test counseling, and it is voluntarily, confidentiality should be maintained. If she is positive, then option of testing the partner and other children if there should be given. She should be counseled for safe sexual practices. We can use ELISA test, antibody test, or we can use ELISA followed by a Western blot to confirm. What we do is 3 ELISA-based rapid tests using different antigen principles, and that has a detection rate of more than 99%. Women should be counseled that ART, cesarean section, and avoidance of breastfeeding can reduce the risk of vertical transmission. Personal prognosis should be given based on viral load and CD4 counts. She should be asked to avoid smoking, drugs, and alcohol. Educate about safe sexual practices. She should be counseled there is no method of prenatal diagnosis to see if the baby is going to be infected or not, and there is no intervention that can reduce the risk of transmission to 0%. An option of pregnancy termination can be given if she wants. Women on ART should continue the drugs, although there may be a little higher risk of preterm labor and diabetes with certain drugs like protease inhibitors. Women not on ART should be started on ART as early in pregnancy as possible to reduce the risk of transmission. OI, opportunistic infection prophylaxis as required. Screen for tuberculosis. CD4 counts can be done every 3 to 4 months to see if the drugs are working and the viral loads are suppressed or not. And screen for gestational diabetes. Routine antenatal tests for any other pregnant woman, and to monitor the toxicity of the drugs that she's taking, we have to do complete count LFT, KFTs every 3 months. Screen for infections as early as possible, and then at 28 weeks, like hepatitis B, C, toxoplasma, syphilis, chlamydia, gonorrhea, because most of these infections are also sexually transmitted and many of them are associated with adverse outcome in pregnancy. She should be advised to have cervical cytology at baseline and yearly, because these women are at a higher risk of having cervical intraepithelial neoplasia. And women on ART should be monitored for drug toxicity. Screening for Down syndrome can be by serum biochemistry, and equal translucency and fetal anomaly scan should be offered. If she requires an invasive procedure, or if she is screened positive for Downs, non-invasive prenatal diagnosis can be offered. If an invasive procedure is required, then it is better to do when she is on prophylaxis with heart, because that would reduce the risk of perinatal infection. At each visit, we should inquire about symptoms suggestive of HIV-related infection, and a full physical exam including fundus and chest every 3 months by HIV physician. Any adverse symptoms and signs should prompt a full clinical and lab evaluation. So what are the different strategies for reducing mother-to-child transmission? These are using antiretroviral drugs. The mode of delivery here is important, and whether breastfeeding should be avoided or continued. How do drugs work for this? They reduce the maternal viral load in blood and genital secretions. They load the fetus with antiretrovirals that prevent transmitted virions from replicating. and they also act as post-exposure prophylaxis when they're given to the newborn. So the landmark study was done which showed in which cidovudine was given for prevention of maternal to fetal HIV infection. Single drug given from 14 to 34 weeks of pregnancy reduced the perinatal transmission by 2/3. So following that, there have been many studies which looked at what drugs to use, how many drugs should be used, when to start, what is the optimum duration of antiretroviral which should be given in pregnancy to be effective. So we have different classes of antiretroviral, and the commonly used drugs in pregnancy are NRTIs, NNRTIs and PIs. So the NACO has adopted the WHO guideline for option B, that is lifelong ART to all HIV positive pregnant and breastfeeding women regardless of clinical stage or CD4 count should be given throughout pregnancy, and it should be continued lifelong after that. So all women would require a baseline evaluation before starting ART, which would include a complete blood count, kidney function, liver function test, blood sugar, lipids, urine analysis, ultrasound abdomen and ECG, HIV-related CD4 count, viral load if the facility is available, HIV drug resistance testing in specific situations, TB-related and tubercular skin test, sputum smears for AAP, so screening for tubercular infection is also important. So what are the different scenarios in which the pregnant patient may present? So a pregnant patient may be one who is newly requiring ART, one who is already on ART, who has had previous exposure to NRTI, because earlier we were giving single dose nevirapine in labor to prevent transmission, or women who present directly in labor and has not received any ART. So if a pregnant woman presents early in pregnancy, we should start ART as soon as possible after proper preparedness, that is counseling and investigations, and continue it throughout pregnancy, delivery and lifelong. Even if the pregnant woman presents very late in pregnancy, including those who present after 36 weeks, we should start ART immediately. And it should be initiated at ART centers only, so that women can be followed up there. So all pregnant women should be linked to ART center. And pregnant women who are already receiving ART, can continue receiving the ART regimen, and there is no indication to abortion or termination of pregnancy if woman has been exposed to efavirenz in the first trimester of pregnancy. For women who have been exposed to non-nucleoside reverse transcriptase inhibitor, if they come for PPDCT, we should avoid this category of drugs, so we should not give nevirapine. Then they should receive tenofovir, lamivudine and lopinavir, that is protease inhibitor based ART regime. So women who presents directly in labor, when should we start? Then we should start ART, and they should be continued lifelong. Use of ARV during cesarean sections. If it's a planned cesarean section, women on lifelong ART should continue the standard ART regimen. In case of emergency cesarean, women who are not on ART can be given a dose of ART and then continued. And cesarean section should be performed for obstetric indications only. HIV infected women who undergo cesarean should receive standard prophylactic antibiotics. If the mother diagnosed with HIV during labor or immediately postpartum plans exclusive replacement feeding, then refer mother for HIV care and evaluation for treatment, and nevirapine for 6 weeks to the newborn. So the newborn receives nevirapine irrespective of whether the mother is feeding or not. But if the infant identified as HIV exposed after birth, then initiate maternal ART and nevirapine, perform infant DNA PCR if child is 6 weeks old or older immediately, and initiate 6 weeks or longer of nevirapine. Strongly consider extending to 12 weeks. That is, if the mother has not received ART during pregnancy, and that is the scenario. If the infant has been identified as HIV exposed after birth and is not being breastfed, then refer mother to ART center after CD4 test and baseline test for treatment. There is no need to give any drugs. Do HIV DNA PCR in accordance with national recommendations on early infant diagnosis. No infant ARV prophylaxis. Initiate treatment if the infant is infected. If mother is receiving ART but interrupts ART regimen while breastfeeding, then determine an alternative ART regimen or solution for her. And for the newborn, give nevirapine till 6 weeks after maternal ART is restarted until 1 week after breastfeeding has ended as a post-exposure prophylaxis. So this is just a flow chart which shows that all pregnant women coming to the antenatal clinic, you have to establish the HIV status. If she is HIV infected case and already receiving ART, then she continues ART as per guidelines. She is HIV negative, counsel her, post-test counseling, or if you think she is in the window period, repeat the test. If it is high-risk behavior, then again in the 3rd trimester, repeat the test. The ones who are detected to have infection should be linked to ART center. CD4 count should be sent. She should be baseline investigations are done, and she started on ART. What ART is given is a combination of 3 drugs in a single pill: tenofovir, lamivudine, and efavirenz. This is the first line of drug. ART center will collect sample investigations, and the mother continues ART during pregnancy, labor, delivery, and thereafter lifelong. An infant will receive 6 weeks of minimum daily nevirapine, and exclusive breastfeeding or exclusive replacement feeding is advised. So what is the effect of these combination antiretroviral therapy? There is no increased risk of birth defects. There was some concern about mitochondrial dysfunction in fetus, in newborns, a woman receiving nucleoside reverse transcriptase inhibitors, and there were initially some concerns that efavirenz causes neural tube defects in hydrocephalus. So is there any adverse outcome with ART? Some studies have shown that combination therapy, especially protease-based, protease inhibitor-based ART, can increase the risk of preterm birth. Women receiving protease-based ART are also at a higher risk of developing gestational diabetes. Whether antiretroviral therapy causes other adverse pregnancy outcome is generally not associated. So how do we monitor pregnant women who are receiving the drug? So we monitor them clinically by WHO clinical staging, the weight, hemoglobin, CD4 cell count, and also for side effects of the drug. So this is basically a table showing the drug. So generally the first line is tenofovir, lamivudine, and efavirenz in single tablet. In women who have been exposed to nucleoside NNRTI, then we do not give them that efavirenz, and they get protease inhibitor. So lopinavir, ritonavir is given. And these are the common side effects with the drugs which we should know. And lab monitoring for these women. So this is basically a chart showing what needs to be evaluated. So clinical evaluation at every visit, adherence counseling, weight, hemoglobin at baseline 2 weeks, 4 weeks, then 12 weeks and 6 monthly. Liver function test baseline 2 weeks and 6 months. Urine test at baseline in 6 months. So this is basically for side effect of ART. CD4 count at baseline in 6 months as per guideline. And other antenatal tests will be done as per for any other antenatal patient. Kidney function test are done at baseline and every 6 months. Screening for other infections should be done like we already discussed, because these are also sexually transmitted and may coexist with HIV infection. Then intrapartum care, the mode of delivery, cesarean section should be performed before onset of labor, and rupture of membrane definitely reduces the perinatal risk even in women who are not receiving ART. And plan should be done at 38 completed weeks before so that the chances of women going in labor are reduced. And it has been advocated by different societies, the academic societies, that if the viral load is less than 1000, then she can be allowed vaginal delivery. But we know that there is no viral load below which we can confidently say that infection will not occur. But definitely if the woman is on combination chemotherapy, combination ART, and the viral load is less than 1000, the risk of perinatal transmission is very low, less than 1%. Peri-op antimicrobial prophylaxis should be given as there is increased risk of post-op infectious morbidity. And women with PPROM coming with preterm labor, the role of cesarean section in reducing perinatal transmission is questionable. So we have to individualize on the basis of duration of rupture of membranes, labor, whether she's on ART, and her viral load. WHO and NACO, National AIDS Control Organization, recommend vaginal delivery and cesarean section only for obstetric indications. So vaginal delivery may be also a woman's choice, and definitely, like I said, if there are combination ART and viral load less than 1,000, the risk of perinatal transmission is very low, and WHO and NACO recommends vaginal delivery. So when we are delivering an HIV infected woman, we have to follow universal work precautions, that is for all cases. And during labor, we should avoid rupture of membranes. So keep the membranes intact as long as possible, because if you rupture the membranes, the risk of infection is more. Then minimize vaginal examination and use aseptic techniques. Avoid invasive procedures like fetal blood sampling, fetal scalp electrodes. Avoid instrumental delivery as much as possible unless required, and avoid routine episiotomy too. Continue antiretroviral therapy during labor, and once the baby is delivered, delayed cord clamping is allowed. Clean the baby after birth to remove the infected secretions on the baby's surface, and avoid methogen in third stage, because with protease inhibitors there is exaggerated vasoconstrictive response, and sometimes with NNRTI there is a high risk of PPH. Safer surgical techniques to be used in conducting any operative procedures as cesarean section. Use of dry hemostatic techniques to minimize bleeding, that is good observation and following of surgical facial planes during dissection. All these are to avoid the risk of infection to the healthcare professionals. So during cesarean section, wherever possible, the membranes are left intact until the head is delivered through the surgical incision. The cord should be clamped as early as possible after delivery. Use round tip blunt needle for cesarean section to avoid the risk of needle pricks. Do not use fingers to hold the needle. Use the thumb forceps. And observe good practices when transferring sharps to surgical assistants, like you should not hand over needles straight away, put them in a kidney tray. So this will avoid injury to the healthcare professionals. So newborn care and infant ARV. So we know that as post-exposure prophylaxis, we have to give all newborns nevirapine for at least 6 weeks, irrespective of exclusive breastfeeding or replacement feeding. Depending on the weight of the baby, the dose is given. And as far as breastfeeding is concerned, we know that if the woman is breastfeeding, it doubles the risk of transmission. But if the mother is on antiretroviral therapy while she is breastfeeding, the risk of transmission is low. So that is less than 5%. And we know that the risk of transmission from breastfeeding is more in early weeks of breastfeeding. What we also need to understand that it should be either exclusive formula feeding or exclusive breastfeeding. We should not mix the two. Mixed feeding is associated with higher transmission than breastfeeding. In our scenario, if the formula feeding is not, there is no access to safe formula feeding, then it's better. If it is not affordable, if it's not safely available, if the parents are not able to give it properly, then it's better to do exclusive breastfeeding, because if not given properly, leading to infections like gastrointestinal infections can increase the risk of infection rather than decreasing. So mixed feeding is definitely worse. So it should be either formula feeding or breastfeeding. So how do we manage HIV exposed infants? The Government of India guidelines are exclusive breastfeeding up to 6 months and continued breastfeeding in addition to complementary feeds after 6 months to up to 1 year for early infant diagnosis negative babies, and up to 2 years for babies who have been diagnosed with HIV and who receive pediatric ART. Postpartum antiretroviral prophylaxis for all infants for a minimum of 6 weeks, whether breastfed or not. Early infant diagnosis is offered at 6 weeks. Repeat testing is done at 6 months, 12 months and 6 weeks after the cessation of breastfeeding, and it is a PCR based test. Co-tramaxazole prophylaxis from 6 weeks of age. So the advantage of early infant diagnosis is that if the diagnosis is made, then the infant can be started on ART early. Co-tramaxazole prophylaxis for all from still 6 weeks of age. HIV care and pediatric ART for infants and children diagnosed as HIV positive through early infant diagnosis. growth and nutrition monitoring for these babies. They receive immunization and routine infant care just like any other infant. Gradual weaning after 6 months and introduction of complementary feeds from 6 months onward, along with continuation of breastfeeding for at least 1 year for adequate growth and development of the child. Confirmation of HIV status of all babies at 18 months using all 3 antibody rapid tests. We have to wait till 18 months to confirm the serology based test because antibodies from the mother are passively transferred to the baby, which may remain in the baby's system for at least 18 months. So to confirm the status, we have to wait for 18 months if you want to do the serology based test. But early infant diagnosis is PCR based. So it can be diagnosed at any time, like 6 weeks, 6 months, 12 months, and 6 weeks after stopping breastfeeding. And if any time it comes positive, then pediatric ART is started. So postpartum care for the mother, to counsel her to continue ART. And we have to also look at the mental health and substance abuse, and if so, needs to be taken care of. Contraception advice is important. The woman has to be linked to ART center. There has to be support services provided to her for managing herself and the baby. So contraception, postpartum intrauterine devices can be inserted in women who are in ART and healthy and have single partner. Sterilization is also an option. But with all other methods of contraception, we have to also advise condom as a dual protection to avoid sexually transmitted infections and further transmission of many mutated virus, even if the woman is positive. There is no contraindication to any contraception. There may be drug interactions, so there is decreased efficacy of oral hormonal pills and hormonal contraception. Both combined pills and progesterone only pills with efavirenz nevirapine, and so that has to be kept in mind. Dipomedroxyprogesterone acetate can be given. So that is all. Thank you.